So I'll be speaking on ptosis evaluation back to basics. When Akshay conceived this very sort of simple IC, we actually all felt that some of these points, like what he presented, what I'm presenting, and the next few presenters are going to do, were just simple things that you sort of need to know when you're examining in the OPD. And these are the little things that you learn as you practice often. So a red flag is like a danger signal or a warning, but often it can just be an alert, like we get in usually in our emails. So it's something that basically it means that you need to look out for something. So in evaluation of ptosis, we go through the sequence of whether there is ptosis or not, whether it's congenital or acquired, unilateral, bilateral, how acute or gradual it is, associated factors, family history, and then final choice of surgery and factors affecting surgery. What we will be going through is just mainly the evaluation. So this is kind of the chart that we do, or even the residents do in the OPD, but we'll just go through the important ones. So here are two ladies. The one on the top has what she thought initially was her eye looked big, but also that her left eye was looking smaller. Whereas this lady said that her right eye was looking smaller. So in this case, she actually has a normal left eye with a raised eyelid, which is causing eyelid retraction. And this lady had enophthalmos, because of which the eye was appearing smaller. This gentleman was complaining that his left eye looked very droopy and small, and I agree, but that's also because it's primarily a brow ptosis and nothing to do with the eyelid position, and it's getting masked because of the brow ptosis. So pseudoptosis is something you should remember, whether it's the contralateral eye or the ipsilateral eye. If you look at this girl, she complained that her right eye was drooping since a couple of months, like just recently. So I said, when we looked at her and evaluated her, we found that, asked her to show her photos, she had a very similar appearance in her childhood. So basically there was a slight angle of the eyelid which was down, and this part, or the tarsal show, was a little less as compared. But if you see, it's exactly like what she was when she was an infant. So what often people feel is not necessarily actually a ptosis. Now this girl did give a history of some surgery and initially was being very evasive, and that she had a drooping eyelid. Of course, the scar said it all, and also that she had a lid lag. So she had 2 ptosis surgeries, and of course, it's sometimes the patients tell you, even if they don't tell you, you're going to be able to know, but history about a previous surgery is very important, especially if you're going to reoperate others, you're going to burn your fingers. Palpable fissure height is pretty straightforward. We need to do it in primary gaze, up gaze, and down gaze, where each one sort of gives a clue, which we'll come to. Then ptosis is classified into mild, moderate, and severe. So when you do a palpable, basically a LPS action, what do we get information when doing or measuring LPS action? Are we just measuring it just to know for surgery? So one, of course, is the severity and the amount of levate action there is. But we also have certain other points we get, such as lid lag. So you have to block out the frontalis action. This is really important. Often people sometimes do it so hard that they push the eye down, but actually you just need to block it out and then ask the patient to look down and look up. He's still trying to use it. I mean, he's a young kid, but that's basically what they do, and even adults tend to do that. So you have to be careful about doing that. Most people know that, but still we should be aware of it. Lid lag is when on down gaze, one eyelid lags behind the other. Often I find that residents also get confused between that and lagophthalmos. So lid lag is very important, because though it is a static sign, what it's indicating is that when you look down and there is a lag like this, that lag will remain post-surgery or worsen, especially in congenital ptosis. So you have to an LPS resection. So you have to point this out to the patients' parents, and let them know that post-surgery also there will be a lag, and which will get exacerbated post-surgery immediately. It may improve but will always remain. So this is definitely a red flag. We have a lot of patients who come and say, no, but we went somewhere else and we were not told this. So actually that I think is not true. I make it a point to emphasize or overemphasize this. Also show photographs pre and post surgery. Coming to lag of thalamus, when you close the eye, there's a little bit of lag of thalamus. Again, this is something that you need to point out, because when you do surgery, especially in congenital ptosis, as was this girl, again the lag of thalamus can worsen. Now she had a very mild lag of, so this is post-surgery actually, you can see the scar. She had, it just worsened marginally, but this is not the case with all patients. So lid lag and lag of thalamus is something you must evaluate. Margin crease distance, basically the importance in congenital ptosis is that sometimes it's very faint and absent and gives an indication of the levator action. And in acquired ptosis, it's basically goes up or is raised, and there's more amount of pretarsal show. Most patients actually who have acquired ptosis often complain of the ptosis, but the fact that they don't like the way the symmetry of the eye is looking. And this actually acts as your point of where you want to put your surgical line. Also, when you operate, a small thing is that as you operate, you also know as surgeons which way your scar sort of shifts depending on how you dissect your orbicularis. So in some patients, you will see a double elevator palsy, and you must check for this because you don't want to end up operating on a patient with a double elevator palsy. Coming to Bell's phenomena is something which we check, and this is exactly how you do it. You lift the eyelid up and ask the patient to gently close the eyes, and it's an upward and outward movement. But in certain cases, this reverses, which basically means it flips and goes upwards, outward, and inwards. That's fine as long as the cornea and eyeball is, having that upward movement. But there are a few incidents where the eyeball rotates downwards, and perverse is when it's moving in all directions. So when it's going downwards, what's important is that if you are going to do a ptosis correction and there's a significant amount of lid lag of thalamus, then that can be a problem for the cornea. So synchinectic ptosis is nothing but an aberrant regeneration of the trigeminal nerve with the external pterygoid muscle, so that when you basically your jaw muscles, as is seen in this boy, he has a ptotic eye, this eye goes up. So what is the importance of this? One is that there's an issue of ptosis and there's an issue of Marcus Gunn. So you can grade this. I really like this grading of Marcus Gunn. Mild is when the ptotic eye goes up by 2 millimeters on synkinesis. Moderate is when it goes up to the superior limbus, and severe is when there is superior scleral show. So mild, moderate, severe are important because they jump up. This is important because when you're correcting a Marcus Gunn ptosis, sometimes if a mild ptosis is there along with a mild Marcus Gunn, then when you correct it just by raising it, it dampens the effect, the amount of excursion that is going. So this is a girl who had a Marcus Gunn. So if you see this photo, you'd probably feel that, no, her pupillary axis is clear, we don't need to do anything. But she did have a progressive refractive error, that too in the form of a cylinder, and she used to drop her eye often. So though she's clenching and lifting it, the fact that she's dropping it often and has started developing a cylinder, to prevent further meridional amblyopia, we operated her, and that's how she is. She had a very poor levator action, and we decided to do a sling. So this is a red flag. Not every patient who comes. So you have to also catch them in their relaxed state. She's actually laughing here because we were trying to make her sort of comfortable. Herring's law is important in acquired ptosis a little more than congenital, because when this eye is ptotic, but when you lift it, what happens is, because of the common innervation to both the levators, because of the yoke effect, sometimes the unaffected eyelid drops. Now that is a very, very important test to do in acquired ptosis prior to surgery, especially in acquired ptosis in adults. In this case, the ptosis is corrected and this eyelid has dropped. Now this doesn't undo itself, so you need to check this before, because otherwise you have to go in and either bring this down, or in some cases in the literature people end up correcting this, but usually people will never agree to correct the unaffected eyelid, so which basically means going back and putting this down. So this is not something like a Bell's phenomena, which sometimes gets altered post-ptosis and becomes normal. Schirmer's test is not so important as in congenital, but in acquired ptosis it's something you must do, especially also now with refractive surgery and known cases of dryness post-refractive surgery. You should do it. If there is a significant amount of dryness, you need to inform the patients that there's a possibility of getting a little bit of SPKs and even some amount of keratitis. Finally, this is a patient. Oh, sorry, that my video is not there. Okay. So, oh, that was a video, sorry. So basically this was a patient, correct. So this was a patient who actually was a thyroid patient of mine. And you can see he has a slight asymmetry which he never wanted to correct. And then he started, he came to me and started complaining of this. Now you see what happens to the eyelid. It's very significant. He actually had a retraction. He was getting very confused because I was telling him to just. So basically what happens is the eyelid starts coming down. So in 48 to 50% of patients, you'll have a thyroid patient who starts developing a ptosis. As you can see here now, very clearly, see the pupillary axis is gone. So he had myasthenia. So these are some things that you should look out for and not end up operating thinking that they've got others, you're going to burn your fingers. So to summarize, a red flag is nothing but knowing the variations in the presentation of ptosis. Documentation and measurements are a must. I often get called sometimes, one or two plastic surgeons called me to operate and said, okay, come and help us in the OT. And I absolutely insist on seeing the patient before, and patient counseling with maybe photographs of how it would look post-operatively is worth it and required.